Okay, ladies and gentlemen, I think why don't we get started? I want to welcome you all
I'm sure
to the Woodrow Wilson Center. My name's Jeff DeBelko. I have the good fortune of directing our Environmental Change and Security Program and coordinating our Global Health Initiative. On behalf of my colleague Haleh Esfandiari, who directs our Middle East program, it gives us a great pleasure to be hosting this session today, this USAID Egypt session that we've entitled Health and Population Legacy Review and the Way Forward, focusing on this Legacy Review report that many of our panelists have worked on, but more importantly, the 30 years of effort on these issues that they, and I can see many of you, since this is already turning into a reunion and catching up, many of you longtime colleagues working on these issues in Egypt and around the world. So it's terrific that we at the Wilson Center who are by law in Congress setting us up to be a forum for exchange between research and policy and within policy and practitioners community can come together to get the lessons learned from the SUSTAIN program on an absolutely critical set of issues in a critically important country and region. It is our pleasure to be doing this. We have our program, I should just say, we've been very fortunate to have support from USAID's Office of Population and Reproductive Health to make the meetings possible from our perspective. So it's wonderful to be collaborating with some of their colleagues at AID. So we're gathered here to mark the release of this report, USAID Egypt Health and Population Legacy Review, that's really honoring a long-standing partnership between Egypt and the United States. The report, I hope you all were given a flash drive when you came in so that you can bring that home and share it with colleagues and read it yourself. It really does cover a remarkable history of effort with consistent strategic objectives, consistent effort, and consistent funding, which I think is a lesson already from just talking to our panelists that I've drawn from what we really need to learn from this project. I'm going to introduce our panelists very quickly and do grave injustice to their distinguished careers by just making it very brief for each one of them. But in the packets that you picked up, you will find their fuller bios and see how distinguished they are. George Lodato is the USAID Administrator Special Assistant for the Middle East in the middle. Mota Sahran is the Political Counselor for the Arab Republic of Egypt, the embassy here in Washington, so it's very good of you to join us. Leslie Curtin is a co-author of the Health Legacy Review and a retired USAID Senior Foreign Service Officer. Dr. Nahid Mata is a Senior Maternal Health Advisor at AID. Dr. Sameh Al-Hasarte is a Senior Health Policy Specialist at the World Bank, who is also on the committee member for the review that produced the report. And last but certainly not least, someone who needs no introduction in this building, Peter McPherson, who's a former USAID administrator, as you all know, university president, many distinguished positions. We will start with Peter. I should say Amy Batson from AID will give us some closing remarks. She's not up here on the stage, but at the very end she'll have a chance to wrap it up for us. But Peter, I'd like to start with you to give us some context, given this was an important mission while you were administrator.
This was an extremely important mission. I think there are three lessons that can be drawn from this experience. One, that long-term efforts are usually necessary to get big payoffs. Two, that economic support funds, the more political foreign policy funds of the foreign aid program, can have very dramatic developmental impacts. And three, you can, when you tie together a country's commitments with a project and a portfolio, you can really make a difference. Comments about all these. There was you'll hear about the impact, but let me talk about the use of the ESF money. We had a lot of money in those days, $1 billion a year. And there was always a struggle between AID and the State Department as to whether it was going to be cash or whether it was going to be programmed. And AID fought very aggressively that it should be programmed. And weren't as always successful as we wanted, but because we knew when something became cash, it always became cash, year after year. So it was, and the story I think that shows all this was when President Mubarak came here, I believe it was about 82, and there was big pressure to provide another $100 million per year of this money to Egypt in cash. And we did not want to do this. But as always, there were critical issues in the Middle East. That's never changed. And the department felt strongly that it had to be cash. President Mubarak, it's not going to work. It's got to be cash. And I recall so well sitting on my porch about 3 or 4 days before President Mubarak came, saying, oh my gosh, I'm just going to be rolled in this one. What can we do? Well, AID had done sewage work in Alexandria and water work in Cairo, and there were, in fact, substantial plans on sewer and water work for Cairo that we'd put together. In the weeks preceding, there had been running sewage on the streets in some parts of Cairo, which was a real political issue for the president. So I came up with this idea, and I didn't have the technical details such as guys like George would have had. Came up with this idea, surely the Egyptians want $100 million, why don't we give them $500 million, except over 5 years and make it sewer and water? So we came up with this proposal to suggest $500 million with certain plans for the sewer and water work. And Secretary Schultz, who was just an unusually good guy and understood us, was supportive. Okay, so President Mubarak comes. We then have and the Egyptians, the President Mubarak liked it, but the question was, but being AID, we had some other ideas how we should do this. We wanted to have rates charged. We wanted to have the money set aside so it could sustain it. And I remember this meeting at the Blair House with Schultz and Mubarak, and for 45 minutes we went back and forth how to do this. Finally, Schultz said, enough, Peter. We got to solve Middle East peace. So the meeting, but we hadn't agreed. So then we went to the Oval Office. And the first half an hour was about sewer and water rates and how to get the money. As George says, this is the only meeting ever, state visit, where sewage was a primary topic. And finally the president said, enough, Peter. we got to solve Middle East peace. Well, in the end, we worked it out. And President Mubarak, with great pleasure, stood there, White House yard there, and announced, the president announced, and Mubarak said it was great that we were going to have $500 million. Well, this set us off. And I think as much as anything, that sewer and water work had our study will tell us all this, but a dramatic impact. Mm-hmm. I can tell more about the ORT and how Mrs. Mubarak, tremendous impact on ORT. Within about 12 to 18 months, we had 80% coverage. And a key part of that was the First Lady of Egypt getting on the TV. Remember those TV ads where she said, you got to use this? And of course, Egypt, with its river, with its population right along the river, had very substantial TV coverage. That's way back then. So the lessons, it seems to me, is that you got to do this is long term. This is not these 5-year plans. This is we got to understand this, and I believe the administrator does understand this. I'm not sure the body politic of this town does yet, but we've got to have some effort must be long-term. And two, don't give up on ESF. ESF can have developmental impact. And three, marry the needs of the country, politically and economically, socially, to the programs, and everybody will drive together to make big things happen.
Terrific. So George, from those lessons, tell us the substance of this 30-year effort that gets us to that sense of the long-term commitment as being so critical.
Sure, but before I do that, I'd just like to thank everybody for this opportunity to talk about this 30-year legacy, because I do believe it really is significant. I particularly want to thank Mr. Montaz Zarhan from the Embassy of Egypt, who has provided real leadership at the embassy here in Washington for many of these development efforts. We're here today to discuss this remarkable legacy of achievement. But as I was going through these remarks this morning, I noticed they said it's starting in 1978, and I corrected that. I said, well, you know, actually it started a lot longer before that. I said, we reestablished an aid relationship in '75. The very first thing we did, before we even put a project number on it, was we helped Egypt by providing a complete fleet of ambulances for Egypt, for up and down the Nile, for the main highways that ran up and down the Nile, the highways that ran towards the canal, and we provided technical assistance from then HEW to set up the systems. And then when I arrived in '76, one of the first projects, I think it was the first project I worked on, was the Rural Health Project, which was, I think, 0011, meant it was the 11th project we put in place. So there's been a long history of working on this effort in Egypt. And I think this report highlights the stunning achievements that have been achieved in Egypt, and it acknowledges and I'd like to acknowledge the key partners for in this success. The change has been substantive, and it's been consistent, and I think that's really important. As this legacy report highlights, there have been some key achievements that are that sort of highlight this effort. The increased access to family planning and health services, improvements in the quality of service, the stimulation of demand for services and the change in health-related behaviors, and finally the fostering of sustainable improvements in health service and working consistently on the health system as a system. And I'd like to go back to that first bullet point on achievements, and that is increases in access to family planning and health services. Least we forget that President Hosni Mubarak was a major voice in supporting this idea, and just a year or so ago, spoke in a major speech in Cairo on the importance of this achievement in Egypt and the need to continue to work on this issue in Egypt. And that kind of sustained leadership around issues like working on health, working on reproductive health, I think has had a real driving force behind this overall effort. The effort's been monitored as it's moved through the process. The Egyptian demographic and health surveys, various project evaluations, operations research, all have been part of analyzing this as it goes on, as it has proceeded, and has been a major driver and a major shaper of the effort as it has moved forward. Obviously, the U.S. put a lot of money into this operation, $1.3 billion over the years, but we shouldn't forget that the Egyptian government put in far more than that, and really, out of their budgetary resources, really made this a key priority in terms of their overall development effort. And just an anecdote, as Administrator McPherson said, I was in the field, I was there in the 70s, I was back in the 80s. In the 80s when Administrator McPherson was leading our efforts at AID, he was involved in these negotiations on the macroeconomic negotiations. This was a time when the World Bank, the IMF, and the US and the government of Egypt were talking about some of the major macroeconomic determinants. And Administrator McPherson led these efforts, but he also came out to Egypt on a regular basis to participate in the discussions with the government. But as I think you all know, Egyptians love to tell jokes. And, one joke they used to say about Administrator McPherson was, "Oh, he's coming again. You mean there's a oral rehydration clinic he hasn't seen yet?" Because every time he came, we went to an oral rehydration clinic or to a primary health care clinic. And he would dive right into the operations of that clinic, talk to the people who were receiving care, talk to the practitioners, talk to the providers. And he set an example, I think, for all of us who are working across the board, that this was as important as anything we were doing. And I think it's having that kind of leadership and that kind of sense about what a good economic development program is that helped keep us on course and helped us support the government of Egypt in a way that has led to the stunning accomplishments that we see in this report. So I'll leave it at that. Thank you.
Thank you very much, George. Mr. Sahran, you just heard about all the commitment that your government made to make these results possible. I'll give you a chance to weigh in here.
Well, thank you very much. Let me just start by saying that this is indeed an honor and pleasure of participating here in releasing the report on health and population legacy review. Briefly, at the outset, let me just say that the report embodies just one sector of a fruitful partnership between USAID and Egypt, and US and Egypt in the broader sense of their strategic relationship and the cooperation that has been fruitfully there for over 3 decades now. It is not my intention to plunge into the details of the report. It's too technical for me. But I would probably rather give, being like the political officer at the embassy, give a few remarks on what the report suggests. It is clear that cooperation between both sides over the years has encompassed a broad range of developmental fields, ranging from projects supporting economic growth to education to health and others. The achievements in the health sector, and this is what the report suggests, and I'm proud to project as well, is a truly success story, and chances of replicating this success story in other fields and even beyond Egypt is probably very pertinent here. The achievements, as the report suggests, also lays down an outstanding example of how USAID can and should be successful in its use of appropriated funds in implementing the projects to the benefit of both sides. Egypt, in this case, advancing its health infrastructure, its health institutions, its expertise, and as a result, its health and demographic indicators. The U.S. in gaining more experience and connections, ultimately, of course, safeguarding its national security interests as a whole. From a political perspective, I would probably say that there has also been the gain of a profound platform for education for both sides. One that has led to better understandings of bureaucracies on both sides. Egypt being, we call it a 7,000-year old nation. Some just go up to 7,000, but we go up to 5,000. We go up to 7,000, which also embodies here, you know, a huge bureaucracy that needs to be understood and to be dealt with. And the U.S. as well, the bureaucracy is still part of the U.S. system, known as red tape, I guess, here at the U.S. But in the midst, opportunities have been grasped, challenges have been confronted and met, and a number of lessons, as we're here to project, have been could be drawn as key to success. And let me just point out two. I had a number of them here, but number one is probably a truly beneficial partnership. One guaranteed through mutual resolve, conviction, trust, better coordination in planning, devising, and executing projects. Two would be local priorities, or what we call country ownership, meaning prominence in identifying projects that are consistent with the local priorities of the country of operations. I think these two, in addition to, of course, respect for the letter and spirits of the provisions of governing the work between USAID and Egypt, is also key, and this is also demonstrated in this report. From the political angle, the underpinnings here of the health and population legacy demonstrates a true partnership, a true strategic vision on both sides to advance, to promote, and ultimately to succeed. I would probably end by saying that at this particular juncture in Egypt's history, we probably need, as much as we did in the past, the efforts of both sides to be geared towards development in times of fiscal, financial, economic crisis in Egypt. I would call this partnership is probably prone to see much more fruition in the future. Thank you.
Terrific. Thank you, sir. Leslie Curtin, we've heard about some teases on the details. Why don't you tell us about some of these significant demographic and health outcomes that you captured as a co-author on this legacy review report?
Okay, thank you, Jeffrey, and thank you, fellow panelists, distinguished colleagues. It's a pleasure to be here. I first visited Egypt in 1981 as part of the early contraceptive social marketing programs, working with Egyptian researchers and filmmakers, and I was also present at 1994 ICPD conference, and I followed the program since then. So it was an enormous pleasure to be asked to participate in actually documenting the achievements that have happened over the years. So very briefly, I will go through some of the impressive demographic and health outcomes, but I do want to point out that there were 10 legacy areas that we identified in the report. Family planning, reproductive health, safe motherhood, infant and child health, infectious and endemic diseases, behavior change communications, quality improvements, health information systems, surveillance and research capacity, and health sector reform, because all of those demographic and health outcomes, as well as health systems improvements, in our view, were worthy of real legacy. So that's why we itemized 10 of them. So very briefly, in about 2 minutes, I'll try and go through some of the major demographic and health outcomes. But first, I'd like to also acknowledge 2 team members who are also here in our audience, Melanie Duffy Tanamli and Carol Carpenter-Yaman. Joy Riggs-Perla, our Haditi Raisa, our dear leader, could not be here with us today. Andy Cantor also prepared all of the demographic charts and analyzed the data over 30 years of Egyptian demographic and health surveys, and Sinar Pinlet. So what are some of these amazing outcomes? First of all, today contraceptive prevalence of modern methods is higher than ever before in Egypt, with 60.3% of women using modern methods. Most urban and rural differentials have vanished, and key determinants of fertility such as median age at marriage and median age at first birth have also increased. It's one of the highest CPRs in the region. Among predominantly Muslim countries, only Indonesia and Bangladesh have CPRs approaching 60%. So as a result of this high contraceptive prevalence, of course, Egyptian women are able to plan the size of their families. They're only having an average of 3 children, whereas in the past it was about 5.6 children over the course of a woman's childbearing years. Jordan and Pakistan, by contrast, have TFRs that are about 4.0. Equally impressive achievements have also been made in maternal and infant health. The maternal mortality ratio, which is maternal deaths per 100,000 live births, was reduced from 174 in 1993 to 55 in 2008. I can't tell you what a remarkable achievement that is in only 8 years. It's a very difficult thing to achieve, and it was done in Egypt in a very short time. We'll hear more about that from Nahed. But by contrast, Indonesia, for example, has an MMR of still around 228. Perhaps some of the most dramatic health improvements also have been made in infant and child health in the last 30 years. Mortality has declined in every part of Egypt, in every socioeconomic and geographic segment of the population. Infant mortality rate, which is deaths per 1,000 live births, was 124 in 1976, and that's down to 24.5 as of 2008, which represents an 80% decrease. Phenomenal. The death rate of children under 5, also 203 in 1976 to 28. Again, an 86% decline. Egypt has one of the highest rates of immunization coverage, with 92% of all children 12 to 23 months fully immunized against the 6 preventable diseases. So polio has pretty much been eradicated in Egypt as of, I think, about 1995. We've heard, sorry? 205. Okay, sorry. We've heard that, you know, in the 70s, late 70s, dehydrating diarrhea caused about 50% of child deaths, and today these children receive adequate treatment. We'll hear more about that. The program also focused on acute respiratory infection, and ARI-related infant mortality declined by 35%, and another 26% by 2004. So you can see that life expectancy from schistosomiasis, which was another just horribly devastating disease in Egypt throughout the course of history, due to the long sustained efforts between USAID and the government of Egypt, that the prevalence of that disease has been reduced to less than 1%. So what I find so remarkable about these achievements is the breadth and the depth of these demographic and health outcomes. Each segment of the health sector has produced such enormous progress, and this in turn has had an incredible synergistic effect on improving the health of all Egyptians. Later on, our discussion will focus on how this progress has been achieved, primarily through strengthening health systems, and what some of the programmatic interventions have been. So thank you very much.
Thank you, Leslie. Dr. Mata, let's focus on maternal health and the successes in lowering maternal mortality. You've been involved in this process or program for a long time. Can you share your insights on what were the most significant strategies to achieve the successes that you've done?
Sure. Thanks, Jeff. It's really a pleasure to be part of this great panel. And and to share some of the wonderful successes. I was privileged to be part of this team effort for more than 20 years during my work with USAID in Egypt, to witness some of those success stories firsthand. Being on the panel with Mr. McPherson, Mr. Ledato, and Dr. Samah really brings back great memories. As you heard from Leslie, very impressive progress was made in maternal health. I will share with you just few. I'll try to be brief. Some of the strategies and interventions that contributed to this success. But please allow me to walk you through some of the historical background that was behind the strategic directions that led to those impressive results. To address the maternal mortality, USAID made a decision with the Ministry of Health to establish the evidence and use scientific basis to learn about maternal mortality, its causes and contributing factors. And thus the first maternal mortality study was conducted in 1993. The study was conducted by MOH staff, Bureau of Census staff, with technical assistance from USAID's partners and experts from the Random School of Hygiene and Public Health. As you all know, they are experts in maternal measurement. The study not only documented the maternal mortality ratio, which was about 174 maternal deaths per 100,000 live births, but highlighted the huge disparity between the different regions within Egypt. With a largely rural population, the maternal mortality in Upper Egypt was 64% higher than Lower Egypt. The difference between the two regions was so pronounced, it was almost as if we are working in two different countries. Many of the major causes of maternal mortality are similar to what we find in other countries, and were primarily postpartum hemorrhage, eclampsia, infection, prolonged labor, and complications of abortion. But some of the other interesting and unexpected, avoidable causes of mortality were due to the mismanagement of the obstetric complications by some of the medical staff and actually the obstetricians. The results of maternal mortality study were used to design AID programs with full collaboration with the Ministry of Health. The program, of course, had to focus on Upper Egypt because of those results. So some of the things we have done. In all of the hospitals of Upper Egypt, about 75 district and general hospitals and some selected facilities where deliveries were conducted, those were renovated, equipped, received a package of essential equipment, drugs and supplies to upgrade the maternal, newborn departments to meet the standards for each level. Some of the critical areas that also were shown to be contributing to the death was anesthesia and the hospital supply section to avoid prevention and infection prevention. The cost of the renovation was co-shared between the Ministry of Health and AID, depending on the Ministry of Health investment plan. So it really was a team effort. At that time, Ministry of Health investment plan was expanding in some of those areas. One of the touching remarks that I still remember very well was a remark from an obstetrician in one of those hospitals during my field visit to district hospital in Kenya. He told me, please thank the AID for making my hospital look like hospital in the developed world. The photos before and after were very impressive. To address the lack of standardization of clinical guidelines, which is as well was a factor there, national standards and protocols for maternal and newborn were developed with Ministry of Health staff and using WHO standard and with the close involvement of Egyptian professors from the various local universities. A large program to train obstetricians, neonatologists, nurses, and other staff was implemented to address the clinical performance skill gaps. The program used competency-based training approaches and strong on-the-job training and supervision with the engagement of the Egyptian professors. The program as well linked community mobilization activities to educate families and communities about danger signs during pregnancy, childbirth, newborn and infancy, and to encourage health-seeking behavior. Similar concepts that were used in the family planning, which is focusing on the male involvement and the role of the men to take care of for their wives and children. To assess and document the progress and impact, AID conducted another maternal mortality study, as Leslie mentioned, in 2000. This study showed 52% decline of maternal mortality nationwide and even higher decline in Upper Egypt. It was around 59%. This was to us a great success. It was really great news. To ensure sustainability of this effort and build national capacity in this area, AID supported the Ministry of Health in establishing the National Maternal Mortality Surveillance System in around 2001. Building on the maternal mortality survey experience of the Ministry of Health, the National Maternal Mortality Surveillance aimed at identifying maternal death on an annual basis, analyzing contributing factors without having to go through expensive annual surveys. I must give credit to the Ministry of Health leaders who were committed to make this effort succeed and were equally committed about the accuracy of the numbers in the early stages. A quality control system was established to ensure accuracy of data. Getting the maternal mortality surveillance to work was possible only because the vital registration and recording of adult death was developed at that time. And that's really a lesson learned if we want to apply it in other countries. All staff at the health bureaus where death is registered were trained on a revised death certificate to assist them to detect a maternal death among all causes of death in females. That's usually the problem. This was a critical first step. Then health teams conducted verbal autopsy for all maternal deaths to analyze causes and contributing factors. Another key development, which is very relevant and important to this effort, was the formation by a ministerial decree of safe motherhood committees at both districts and governorate levels to analyze every reported maternal death and examine contributing factors and work towards a plan to address the gaps and avoidable factors. I have been in those committee meetings and heard MCH directors at the district level memorizing the name of the woman who died and were committed to prevent another maternal death from causes that appeared so much avoidable. I was delighted to hear and learn that the maternal mortality surveillance system continued to report progress, and now we have a maternal mortality rate of 55 in year 2008. So thank you so much. I'll stop here.
Well, thank you. Although, can I ask you a quick follow-up about some of the child health figures too, because I think those are important to get out there in quick summary as well.
Yeah, what I will do actually, I will reflect on some of my memories of some of the key child health activities that was conducted when I was working there. Because these as well, the child survivor program, were another success story. We've mentioned ORT, and I can't not mention that because Egypt's success in initiating from scratch, I think the knowledge and use was like almost zero, to scaling up oral rehydration therapy, ORT, at a national level during the 80s was phenomenal. Mr. McPherson was so supportive, as we heard. He was after us and was visiting all the facilities to see whether that's real and happening. And I think the trick was the mass media campaign between having Mrs. Mubarak on. We had another important mother figure who was a famous actress, yes, who was on TV and actually encouraged all the families and showed what's the dehydration and so on. So ORT introduction, use and knowledge became 90% in just a few years. USAID, I don't know whether it's appearing in the report now, but USAID helped in sustaining this effort by helping the government to establish production lines for ORS in a public sector pharmaceutical company. So now ORS is really in every facility and in all pharmacies all over Egypt. Another area where Egypt showed progressive strides is the immunization. The rate, as we heard, for children 12 to 23 months fully immunized against the 6 basic vaccines is 92%. But what's critical, I think even 10 years back, the data from DHS was very similar to the health information system of the ministry. and so that proved that it's reliable, and we're getting really good data through the classical health information system that Sam, I'm sure, will be addressing. USAID also was a major partner in a polio eradication effort, which was championed by several Ministry of Health officials at all levels. I witnessed great collaboration effort between AID, WHO, UNICEF, and the Rotary International, led by the Ministry of Health, to plan for national, subnational immunization day campaigns to address gaps in the system and reach the few remaining unimmunized children who are allowing this polio virus to circulate in the community. USAID budget was flexible, and the Ministry of Health was serious in this effort and allowed external observers to visit all regions and villages to monitor the immunization campaigns. I joined in several of these house-to-house visits, and as we know, in year 2005, the last case of wild poliovirus was actually mentioned, and since then I don't think we have any further cases with wild polioviruses. I think this will be my last point, and something that I don't want to miss not sharing it with you is a USAID role in introducing hepatitis B vaccine to infants. Sitting with you here today, I'm very happy to report that AID's leadership then decided to fund the introduction of hepatitis B vaccine in 1992. At that time, I was worried about my program because that was a new area, and it was costing around $4 million to buy vaccines for 2 years for all the newborns for 3 doses. So personally, I was worried that that might affect negatively other parts of the program. But I'm so happy to say, and for that decision to be made, that because of this initial purchase, this vaccine became one of the routine vaccines added to the 6 other vaccines. And after AID provided the purchase for 2 years, the ministry took over. And because of this initial assistance, the government now is buying hepatitis B vaccine with their own funds, and every kid is getting it free all over the country. I want to take really this opportunity to thank AID staff. Several of them are here today, both the US and Egyptian, the Ministry of Health officials at central governance level, and all the Egyptian and US partners who contributed to this effort in many ways. I want to give special thanks to the current team in the mission who commissioned this legacy review and documentation. Thank you so much.
Thank you, thank you. Dr. El Saharti, you have been working on health issues in Egypt for many, many years. You were instrumental as a member of the advisory group for this legacy review. Can you share some of your insights on the health systems and health sector reform aspects that are captured in the report and obviously are part of the legacy that we're looking at?
Thanks, Jeff. First of all, I'd like to thank the organizers for inviting me to be part of this very distinguished panel. And as it was mentioned, it seems like, USAID Egypt alumni reunion. So I'm really happy to see many of the colleagues that I've been working with for quite some time. I think at the outset, listening to the results that were presented by Leslie and Nahed, it's important to understand that these results were not achieved in vacuum. I mean, evidently there were systems that were built, effective management and institutional capacity that were put in place in order to achieve those results. I don't have the time really to go over all these systems, but I'll just pick 2, in my view, that are sort of the most critical of these systems. First is human resources development, where USAID has invested 4 years in so many programs to ensure that the health sector has adequate supply of professional cadre. The participant training program, the young scientist program, the field epidemiologist program. I mean, you name it. Over 15 years, the support to the higher institutes for nursing that were then converted into faculties ensured adequate supply of qualified and skilled nurses and midwives. The Regional Center for Training in Family Planning and Reproductive Health was developed about 30 training courses and was training approximately 250 professionals, healthcare providers, every year for 20 years. At one point, speaking about the training, the participant training program, at one point, 2 of the first undersecretaries at the Ministry of Health headquarters were trained under this program, obtained their master's degree with USAID funding. But that was like 15 years earlier. I mean, the examples are numerous. This is just to give a snapshot of the investments that were made in building the capacity in human resources. The second system is what I would term health systems intelligence, which refers to the generation of information that is needed for making informed decision. We could not have presented all these results unless we had systems in place that would monitor progress and be able to guide us in terms of implementation and changing course. Again, examples are numerous. The routine health information system to collect data related to maternal and child health, family planning, and reproductive health that was established from the primary healthcare facility level up to the district hospitals, general hospitals, up to the central level at the Ministry of Health. The electronic national epidemiologic surveillance system that was established in 2006 that is now operational in all the governorates. The logistics and management and chain management supply system that was established with the Egyptian pharmaceuticals and trading company to monitor the contraceptive supplies and ensure that there are no stockouts. Then, talking about surveys, 6 rounds of demographic and health surveys, plus interim demographic and health surveys, numerous behavioral science studies, maternal mortality surveys, operational research in family planning and infertility and reproductive health, national health accounts, budget tracking systems, political analysis, institutional analysis. I mean, I can go on and on and on. This is just to tell you, this is what you need to invest in order to be able to sit here and tell this story. It's not something, that you can do in just a 5-year program or even a 10-year program. Now let me say a few words on the health sector reform. Health sector reform was sort of a paradigm shift and a game changer in a way, because up to 1997, 1998, the focus was on specific programs, maternal health, child health, hospital management, and so on and so forth. The health sector reform actually encompassed a broader set of programs as well as health systems. And it was a game changer in the sense that it was done not just USAID with the government of Egypt, but also in collaboration with the World Bank, the European Commission, as well as the African Development Bank. So in that sense, there was a very powerful mobilization of technical assistance to support the health sector reform program. Just to put things in perspective, the objective of the program was to increase universal health insurance coverage. The WHO, the World Health Report that was launched this year, speaks about universal health insurance or universal health coverage. That effort Egypt has started back in 1997, just to tell you how far Egypt was ahead in this game. Also, to put things in perspective, in 1964, Egypt has established the Health Insurance Organization to cover government and public sector employees with health insurance, with the aim of covering the entire population in just 10 years, in 1974. Until 1990s, early 1990s, only 30% of the population was covered. And the thinking was to cover them in a fragmented way, in the sense that, public sector employees, government employees, employees of large enterprises, students, and so on and so forth. And then rolling it out to fishermen, farmers, and so on and so forth. What the health sector reform has done was completely different, covering population based on residence, on a geographic basis, and the second, not as individuals, but as families. Before it was just individuals. If you're working, then you're covered. Your family is a different story. So you had a very fragmented coverage. In terms of the legacies, what health sector reform has done, I'll focus on two aspects. One, on the service delivery. A family health model was developed, basically reforming the service delivery infrastructure to have family health units and family health centers developed based on certain standards and criteria. A very robust quality improvement and accreditation system was established. A basic benefit package encompassing primary and secondary healthcare services was provided, and it was piloted in 5 governorates. In fact, this model, the government of Egypt, using its own resources, has adopted and then adapted the criteria of the family health model, and on their own, all the primary healthcare facilities in Egypt are now developed using this model. That's, I would say, a very important success. The second aspect on health financing. A family health fund was established to cover this new insurance scheme that separated finance from provision. One of the, I would say, the important characteristics of ensuring quality and efficiency in service provision. So the family health fund was established that contracted out with providers, both public as well as private. Also, providers were paid based on their performance. Again, for the first time, not only they were taking salaries, but part of their payments was related to performance, whether in terms of efficiency and or quality. Let me just close by saying that many of the elements in this program made it into 2 draft laws for reforming health insurance in Egypt, and were submitted to the parliament. For different reasons did not pass, but the idea is, having invested in such a program, I think yielded so many results and so many lessons. And I think we all should, both government of Egypt as well as the US government, should be proud of these successes. Thank you.
Thank you, Doctor. Well, I'm eager to get to questions from our really expert audience, but Leslie, I don't want to forget to ask you about communications and the role that played in changing social norms for both family planning, but also in a broader sense as well. Maybe just a minute or two on those.
Sure, very briefly. I think behavior change communications was one of the most important systems that really helped to change norms in Indonesia. And it's a long story, so I won't go into it.
Indonesia too.
Sorry. And it has to do with how the evolution of the family planning program evolved, and maybe we can talk about that during the question and answer period. But basically, we talk about one of the lessons learned as this program being very flexible and very adaptive, and in fact it really, really was. In the early stages of the program, when family planning was a vertical program, the messages first were designed around reducing population growth. And it worked to increase prevalence by about 10%, and certainly raise attitudes and raise awareness, but it didn't really do anything to change prevalence substantially. So an effort was made to make those messages much more specific with regard to family planning itself, what it is, what the methods are, where you can achieve quality services. It was adding value, and it made people understand the economic benefits of a smaller family as well as where they could get the services. So it really linked supply and demand, which was absolutely key to getting prevalence up. But in terms of your question about what's happening today, I think it's also a very interesting phenomenon that again talks about the evolution and how strategically wonderful this program was in evolving appropriately. When you had the vertical program of family planning and communication materials around that, the vertical program around maternal health, or child health actually, and the communication programs around that. But then as the program became integrated, so did the communication materials. So it moved from vertical programs to integrated programs. The communications themselves moved to integrated programs. But now today, it's gone even further and gone even beyond just family planning, maternal health, infant health, to a life cycle approach, which consistent with how the communication channels actually evolved from a primary reliance on mass media to a more interpersonal communication approach, and now involves the community through community mobilization efforts. So that you've got, in practically every community in Egypt, there is a community mobilization team that talks about, has messages directed to each member of that family, from the youngest children to the youth, to the early married couples, to even through the older populations themselves. And I participated in one of these events, and I just can't tell you how impressive it is when you've got a sheikh talking about the value of female education to the family, or a woman talking about the value of how health improved her productivity and her economic ability, and how that empowered her within the family. Just a phenomenal story.
Terrific. Thank you, Leslie. Well, as I said, and as we can all see, we have a very distinguished audience as well as panel. So we've heard about how this got started and some of the leadership from the very beginning, and how then, in very stark terms, we have many, many successes from this partnership with Egypt and the U.S. government. Why don't we throw the floor open for discussion? We'll ask you to use a microphone and state your name. Given how many interesting topics we'd like to cover, I ask you to keep it very brief. Maybe we'll collect a few and then let our panelists divide and conquer in answering them. So shall we start on this side, maybe David Ottaway, and then we'll come over on this side?
Dave Ottaway, I'm a senior fellow here, and I was the Washington Post correspondent in Egypt back in 81, 85, when Peter referred to the sewage crisis. We lived, our house was in the middle of it in Doi. I have a question about family planning. One of the last articles I did towards the end of 84 or beginning of 85 was on family planning. And there were even buses in Cairo promoting family planning. And the immediate reaction was so adverse from the Muslim Brotherhood and the Muslim militant elements of Egyptian society, is that the buses were immediately painted over, and there was tremendous opposition to the family planning program. It was being denounced either as Zionist or imperialist, and a plot to reduce the population of Egypt, et cetera, et cetera, et cetera. So I'm absolutely amazed at the success of your program in reducing the average size of the family from 5.6 to 3. And I'm wondering how much of a problem the Muslim Brotherhood and their people of that thinking turned out to be in trying to promote your program.
Okay, terrific. The microphone, we pick up a couple over there. Yes, please, sir.
Scott Moreland from the Futures Group. We've heard a lot about the high-level political commitment. We recently, Leslie was talking about the behavioral change communication. I wonder if you could reflect a little bit on some of the societal changes that took place over the last 30 years, particularly that may have contributed to the sustainable demand for these services, such as increase in women's education, urbanization, increase in standard of living and modernization, all of which would contribute to the demand for these services, but wouldn't necessarily be part of the supply side.
Okay, why don't we stay right there? I see Nancy right behind you. Scott has a question. Again, we'll get to you.
Nancy Harris from JSI. Very nice panel. I'd like to hear the panelists tell us what remains to be done in terms of, and especially in terms of political changes, both in terms of the gaps that still exist in the healthcare system and how it's going to play forward given the political changes in Egypt. I think that would be the important is what's the next step? And then one more question is how can we do it less expensively in other countries? Because obviously we can't invest the same amount in every country that has the same horrendous problems that Egypt started with and has conquered.
Okay, why don't we take those three, and who would like to kick us off? George, would you like to jump into the fray?
Well, on the issue of Mr. Ottaway's question about the family planning program, I do recall that one of the early things that was done was to engage the Grand Sheikh of Al-Hazar in putting forth a message of the consistency of this kind of programming with the tenets of Islam. And in fact, I think that was also picked up and used in other countries. And I have a feeling, although I'm sure there are people in this audience who understand the family planning and reproductive health program much better than I do, but I always had a sense that that was a very important foundational block upon which the program built this effort to reach out to Egyptians to say this is consistent with our values and our religious beliefs.
Yeah, if I may add, that's true. We engaged the religious leader, the Muslim religious leaders at all levels in this. And there were several booklets writing that hints that the Quran is supportive, and it's not the number, but the quality of the generation, because that's the misconception, that more kids are better, but more kids that would die is not better, and Prophet Muhammad was encouraging quality versus number. So over the years, the message has changed, but the involvement of the Muslim leaders were brought in developing those messages, and they were culturally sensitive, and they were talking about the impact of spacing on health. The spacing message was important because truly, and some of the DHS data showed that closely spaced kids would die more frequent, so spacing will ensure child survival, and all those factors together help convince. So we hope this message will continue, because I think it's involving the religious leaders was key in doing that.
If I may add, it's not only that the religious leaders were, conveying these messages that it is, acceptable within the Islamic teachings to have family planning and contraception, but also related to what Scott asked about societal changes. One of these changes is education and the technology, and these are sustainable. Also, the behavior change. You cannot take away those behavior changes once they are there in the community, even at the poorest levels. And these messages existed before and will continue to exist. And it's part of, different views. But in general, the Egyptian society is very moderate, and not all having more children is not just for religious reasons. Some of it is for poverty and income. Having more children in certain segments of the population is to generate more income, and also as a way of social safety nets. So when the parents grow in age, they have more children to support them when they grow up. So I think with improvements in education, in social safety nets, and reduction of poverty, these messages will disappear.
Well, there's no question this was a real political issue, David. I remember the meeting with President Sadat, actually there in Alexander, and sitting out there in his, remember he had that, I guess it's still there, the beach, the house near the beach, and he said, family planning is a real political problem for us here, Peter, and I'm supported, and we need to get it done, but it's a real problem. And I think that the Brotherhood that's all part of the history that unfolded. I think the key, and I look at many countries, Catholic countries as well, many in Latin America, we had the same kinds of issues. The key thing wasn't to bring the argument that there needed to be fewer people, which is what folks often argue here.
The early days, certainly.
The early days particularly. It was about the health of the mother and child. You bring it down in those individual personal terms. And then it's a different kind of discussion. And that was, in fact, the fair way to talk about it. I've got other comments, but I need to stop.
How about what remains to be done, and how do we replicate this, perhaps with using fewer resources?
I would definitely like to get to that, but may I just add one thing that Mr. McPherson said in one of our early interviews, which kind of responds to the question that Nancy raised back there. I think female education was extremely important, and urbanization, and also just the role of women in general in Egyptian society is high. It's relatively higher than in a lot of other countries in the region, and I think that is also one of the socioeconomic factors that has contributed to the huge success of this program.
Absolutely.
So challenges we can move to.
Well, I mean, you've got some tools today we didn't have back then. Some of them are incremental, but they're real. Around the world, there's higher literacy than there was, let's say, in the 1980s.
Absolutely.
And literacy really contributes in a lot of ways to implementing health programs. We've got this mass media. We've got the capacity to get information from the field and have people be able to link in. It still costs money, but there are ways to mobilize. I do think that, and I believe my colleagues here would agree, that it does help to have sort of Jim Grant kind of mobilizations. Grant, who I hope we never forget, our great old man Jim Grant, has had a UNICEF. He was the one that really said you can mobilize a population with vaccines and then ORT and so forth, but it tends to pull along, and there was big debate about it. Remember back then, this is just short term, it won't last, and but in fact, tied into long-term efforts, it mobilized. So I think information technology, literacy, mass media, done right, we can make progress, and governments need to be in control of it. I mean, the fact the Egyptian government wanted to do this was critical. Too often we go into countries and we say, well, here's what you ought to do. Well, this was, when I look at these figures, I see the figures and I'm so pleased with all that's being done, but behind these figures are hundreds, and really, when you look at deeper, thousands of people, individual stories of true dedication, the AID and the Egyptians. You can't, stories known only to a few people separately, but I see around the room, you worked really hard to do this, and it's, isn't it nice to see the legacy you gave?
Why don't we capture some more questions?
Well, what about challenges? Sorry.
Yeah.
Okay. Well, one challenge is going to be keep these folks happy and give them a chance to ask questions.
Okay, just briefly.
So, a quick on challenges going forward.
Okay. Nahed, you want to go first?
Sure. What remains to be done? Definitely, all those investments need to be sustained. So I think there was effort, as Samah mentioned, in systems. So the systems are there. And I think the training programs that was implemented went through the whole system. Senior level were involved, and local level and community level. So the structure is there. I think for the ministry and the government to sustain is just building on what's there and making sure that it's not lost. The maternal mortality survey system, I'm so impressed of how this saved millions. The survey, the maternal mortality survey, cost $1 million to conduct, and AID was able to pay for 2 of those surveys. When it's a surveillance system, it doesn't cost much. It's part of the regular work of the Ministry of Health and the health bureaus and the MCH directors, and they know how to do it. And that certificate was revised, you will know, with 3 questions just to be able to find the maternal death, which is lost within female death. So I really hope that what's remained to be done is sustaining it, which will not cost as much as the establishment and developing all of that. So that's what we hope that the mission and the ministry will continue to do. In other countries, definitely we bought the hepatitis B vaccine. Now we have Gavi. So there are other international venues which is helping, and I'm seeing several of what we're doing in Egypt is happening in many of the African countries with the partnership of the different donors and with USAID, the Global Health Initiative, where they're looking forward in addressing a lot of what we learned from Egypt. The government ownership is there, focusing on women, and we'll hear Emmy talking more about that. And we're doing that in several countries. I'm now privileged to work in a project that's implemented in several countries, building on my experience working for Egypt. I'm happy to say that several of what we're doing now, it's lesson learned that other countries are taking it. So I think it's happening. Yeah.
May I just add quickly to that? Because I really don't want all of us to go thinking that the job is completely done. It's really not. We have a huge challenge overcoming the fertility plateau. We've seen that our last DHS survey was 2008, and fertility is at 3. The Egyptian government has expressed a desire to get it down to replacement level fertility within the next 8 years, which is another, get it down to 2.1. That's going to be a huge challenge. We're going to need to overcome additional social norms within Egypt. I think we've got a challenge in terms of getting knowledge out on this new health insurance, the health insurance models that are out there. People don't really understand what it is, how it's going to be implemented, how it's going to affect them. And then we've also seen changes in mass media. In the old days, the SIS provided a lot of mass media for free. That can't happen today. So there are a lot of cable channels. The whole mass media environment has changed in Egypt, which in effect is providing a little bit of a challenge to us. We're seeing evidence of a decline in the knowledge of pregnancy danger signs and so on. So I think we have to challenge ourselves to use the information technology to keep these health messages strong.
Terrific. Thank
Sorry,
you. No, that's good. Okay, why don't we move right up the table? So if we could bring the microphone to this gentleman here, and then Kendra, while we're waiting, we get the mic to her so she's ready, and then right behind her.
Is this on?
Yes, sir. Go right ahead.
Okay. My name is Warren Robinson. I'm a retired academic who had the good fortune of working in Egypt for several years. And I think it's important that the Egyptian program be seen in its larger international context too, because it was a very important program in teaching the larger world community of family planning 2 important lessons. One, excuse me, is that this was an Egyptian program. Somehow we don't want to get this mixed up as though it's an AID program, because one of the frequent charges, as you know, against such programs is that they're foreign interventions which are being shoved down the throat of the hapless local people. That's not Egypt. This was a program before AID arrived on the scene. And indeed, AID helped save the program from the wrong path, which UNFPA and some other donors were doing their best to lead them down. The second point,
we won't talk about that.
The wrong path really was the path that said you've got to do all these other things like village development and female education and female employment circles first. Those are prerequisites before women will take to family planning. That turned out not to be right. It did not turn out that we needed to do one or the other. They worked together.
Right.
Indeed, family planning was an important intervention which made some of these other interventions easier.
How true, huh?
So
Yeah,
that
that's
woman
good.
had been to
So
the
true.
clinic and understood
Yep.
she could control her own fertility, also was much more interested in education and much more for her children and much more interested in many other things that development is all about. So I think Egypt has really been a bellwether, kind of a cutting edge in teaching some of these important lessons to other programs. AID has its role, definitely, mainly that it had more money than it knew what to do with, and it could make mistakes and let those mistakes just wash away. It didn't matter then. That's an important thing. Maybe the future programs won't be able to afford that luxury, and they will have to be a little bit more careful. Thank you very much.
Thank you. Ma'am?
Thank you.
My name is Bushra Jabr. I'm with Johns Hopkins University, the Center for Communication Programs. We've been involved in Egypt for many years, and we've seen the program shift from family planning to reproductive
We can't hear
health.
you, ma'am.
You gotta speak up just a little bit.
Sorry. I've been involved in the Egyptian program for a long period of time, and I've seen it shifting from family planning proper to reproductive health to maternal and child health integrated. And the component of women's empowerment and community mobilization on it really made it much, much easier for us to convey, to work on the changing the social norms. So the Egyptian program has been an experimental lab, which has really provided us with many, many lessons that are applied in other countries. And I really would, push for this integration between the health as an entry into community development. Thank you.
Ma'am, if you could pass it just one row back. There we go. Thank you.
Thank you. May Rihani from AED. First, let me thank the panel for this excellent presentation and for capturing results and achievements. This is powerful, and for giving it to us through quantitative and qualitative. Thanks a lot. I want to build on many comments that were said here, and I want to build on it, to emphasize it, to underline it. I do believe the success is because of the integrated approach. If we talked about a siloed approach, we would not have reached where we reached. If we talked about family planning, maternal health, and so on, we would not have reached where we reached. If we talked about those two and integrated them without girls' education, we would not have reached where we reached. Girls' education is a pillar to what you're doing. And to unpack it, not to say just education, we need to unpack it, and not to say just girls' education. That's not sufficient. We need to say secondary girls' education. That's where behavior changes. Until we understand that, I do not think we are capturing one of the major lessons, which is all of these results. Oral rehydration, go ask Jim Grant, and let Jim Grant tell you that the basis is girls' secondary education.
Right.
It does not happen without
Right.
that. So we need to put it in from minute one when we present that that's one of the lessons learned, that integrated approach that includes education, in particular girls, in particular secondary. Thank you.
Terrific.
May I address that? May I just say one thing in response? I agree of the value of girls' secondary education, absolutely. Often, however, our funds are directed toward health programs, so it's a separate program within AID or within the other donors, but absolutely, it's key. However, I do have issue with your comment about the necessary integration. I do agree that that's critical, but in Egypt, why it worked is because we had already achieved a certain level of family planning contraceptive use and a certain level of infant mortality reduction. And that could only have been achieved through vertical programs and building the systems within those vertical programs. Once a certain level had been achieved, then you can integrate, because the systems are already there to enable you to build successively on it. So I just wanted to make sure that key point was raised as well.
Thank you,
Thank
Leslie.
you.
We're going to get one more question here, then give you guys a chance to respond, and then we'll invite Amy to close.
Blatt. It's very pleased to hear Pete McPherson's remarks about the early days and the programs in water supply and wastewater disposal. But I'd like to pose this question to George. Given the expansion of Egypt's population, what's happened with respect to, one, expansion of these water wastewater systems, since they're clearly important in preventative health? Secondly, have they been maintained? And thirdly, some of the areas that Pete worried about once upon a time, what kind of tariff structure? Are they sustainable?
Okay, George, why don't we start our final remarks from the panel with you on that question.
Sure. Well, let me start by saying we're still doing some water and wastewater work in Egypt. We also have, over the years, migrated from the capital infrastructure to the institutional work, and have done a tremendous amount of work with various institutions of the Egyptian government and the various semi-autonomous holding companies that now manage these systems. I believe that we're fairly confident that that work is proceeding and continues, and Egyptians have taken over this concern. I think that's probably the hallmark of this effort. Where I don't know specifically where the Egyptians are in terms of tariffs and for water and wastewater, but I do know that there are ongoing efforts to continue to increase tariffs and also to manage household connections, and then on the larger capital infrastructure, I think the Egyptians have done a very good job on the maintenance of large capital infrastructure. That certainly the things that we have been associated with. But I think, obviously the financing has shifted. Egypt does a lot of its own internal financing now, and bond financing for this. But I think we're fairly satisfied. I thought, Sai, you were going to ask me the question you asked me the last time we were in this same situation, and that is about the training, because I think you make the point very, very effectively that it was the result of these large capital projects, particularly in water and wastewater, that Egypt managed to through these projects, to train some of the best technical people working on capital infrastructure certainly in the Middle East. And one only has to travel throughout the Middle East to realize that Egyptian engineers and Egyptian systems people run so many of these major systems independent of what country you're in. And I think that traces back to the enormous amount of, as you point out, the enormous amount of training that was done by the firms that helped us. And I'd like to, since this may be my last comment, I'd like to do a shout out to the firms that have helped us on this effort, both the firms that worked on the capital structures, but also and I'm going to miss somebody, and so don't get mad at me, but the John Snows of the world, the Futures Group, Apt Associates, Management Sciences for Health, JPIGO, all of you, AED, all of you have done a superb job and have been superb partners on this. And I think you know as well as any of us sitting up here that we wouldn't be where we are today on this issue if it hadn't been for you. Thank you.
Thank you. Mr. Zahran. Mr. Zahran, your reflections?
Sure. Thank you. Just to go back to the family planning issue and the successes that have been achieved there. Again, injecting in my political angle here in this very useful presentation, I would probably just say that it's the fusion again of creativity, authenticity, beliefs all coming in together and yielding these positive results. And again, it also brings me back to the one of the important lessons that I had in fact mentioned, which is the local ownership, the priorities of the local government. And this is where success is probably best to be achieved. Thank you.
Dr. Al-Sahar.
Okay, just quick 3 reflections. First on the integration. I think, yes, it makes sense to think of integration as one key factor for success. However, in retrospect, thinking of 1970s and early 80s, it would not have been possible. The system was so weak, and the way the structure on the government side was in such a way that you have to work in vertical programs. And also, I mean, in my view, there is a certain threshold below which you cannot integrate. Both or all programs will fail. You have to build the capacity little by little until a threshold is reached. Only then you can think of integration. In terms of what remains to be done, I think I fully agree. I mean, capital investments are not that much needed, and Egypt has been able to actually take on capital investment, as we've said, and we've seen in the family health model, on their own, using the government of Egypt funds. They were able to scale it up nationwide. I think what remains to be done is mainly the soft part of development, knowledge transfer, information technology, and continue to building the institutional and management capacity. One last thing. Egypt is a success story. And one thing that we can do is promote Egypt as a success story and fostering South-to-South collaboration, so that, you know, inviting other countries to Egypt to learn and vice versa. I think this role USAID can play very effectively.
Okay, sure. I don't want us as a maternal health expert to say we did it alone, because that's not true. What happened was witnessing economic development and growth in Egypt in general, so electricity was better, clean water was better, better sewage system, and certainly female education. However, we can say that early on, like 20 years, when the mother who was not educated still took her kid for immunization, the mass media communication and one-to-one communication was important. So definitely we're for female education, and all what happened that we discussed was one factor was it was the strong maternal and child health programs that AID and the ministry did, but prior to that a lot of other development was happening. So we don't want to neglect this or that. I think I want to mention, we might have not mentioned the contribution of several organizations, and I will list them here if you don't mind, because this effort and this success was not possible without the contribution of the Ministry of Health and Population at all levels, the National Population Council, the Cairo Demographic Center, the Teaching Hospital Organization, Ain Shams University and Regional Training Center, the Health Insurance Organization, the Ministry of International Cooperation, and El Zanati and Associates, and several of the universities of Egypt. From AID side, I want to thank, of course, AID, Washington, and the mission. Center for Disease Control contributed a lot to several of the programs we mentioned, the National Institute of Health, the Department of Health and Human Services, the Naval Medical Research, the NAMRU 3, a number of U.S. universities, and USAID partners and contractors that Mr. Legato mentions just some of them. Thank you.
Okay. That's a nice way to end it.
It is. Well, I would like to invoke Duff Gillespie's name here before we close. He was such an early supporter of this program. He used to say, it's not enough that we do things right, but that we do the right things. And I think this is testimony with both our Egyptian partners, the huge level of commitment and cooperation by our Egyptian counterparts and their host country commitment, as well as our long sustained funding has led us all to do the right things. Thank you.
Administrator McPherson, give you the last word on the panel before we turn it over to Amy.
Well, we frankly were not successful in our economic policy discussions with the Egyptians. It was only in the last several years that the Egyptians, a country needs to decide its own fate, of course, decided that they were going to make some real opening up of the economy. And I think it is key that we worked in other areas, not just in economic policy discussions. We worked in an area, this area, where the country was driven for its own future. Mm-hmm. And to me, that's this country, you look around the world, the countries that have made real progress in various sectors have been when they decided they were going to do it. Absolutely. And it's not easy for the technician to really get hold of that, but it's true. The USAID needs to put its resources where countries, where their ideas and our convictions match, plus the human resources. I hope that in the years ahead, the U.S. continues to put a lot of money into the soft side, the human resources, the institutional building.
Terrific. Well, thank you all very much. We're fortunate. No, sir, I'm afraid we're over already, and so I'm going to urge everyone to come catch people on the panel when we're done. But I'd like to invite Amy Batson, who's a Deputy Assistant Administrator for Global Health, to join us on stage, have a mic for you here, and close our session, and then we can continue the conversation informally.
Thank you very much. I'm very grateful for the opportunity to close this important discussion today. I'd like to thank all of the panelists for taking the time to come and to share their important knowledge about this program. I'm truly honored to be here with such a distinguished set of panelists. Mr. Zahran from the Embassy, our former USAID Administrator, Mr. Peterson, my colleagues and partners, and Dr. El Suarte from the World Bank. The wonderful team who created the Egypt Legacy Report also needs to be recognized, as well as GH Tech for organizing this event. The most inspiring result of this partnership is not just the number of mothers, infants, and families in Egypt who are living healthier and safer lives, though this is indeed incredibly impressive. What makes me proudest of the successes that we've been listening to today is that we are taking this learning and using it to really improve how we are working with governments around the world, how we are investing our health dollars to have even greater and more sustainable impact. And this is through President Obama's Global Health Initiative. When I look at the report, and I've listened to the panelists, I'm very struck by this word legacy, and indeed it is the legacy in Egypt as well as a legacy that we hope to see reflected around the world. The work of the Egyptian government and the Egyptian people, with the support provided by USAID and its partners, is truly a legacy, and one whose impact we are really seeing every day. Quite possibly one of the greatest impacts of the partnership is reflected in the women of Egypt. We don't often have the pleasure of pointing to achievements like a 72% reduction in maternal mortality in Upper Egypt, nor programs that have resulted in every married woman empowered to make informed choices about modern contraception, or even immunization programs that are reaching 92% of their population. This kind of success is especially critical today as we all strive to achieve the Millennium Development Objectives. So I want to just flag three particular areas: country ownership, monitoring and evaluation and transparency, and innovation. On country ownership, and this is an issue that I think many of you were highlighting in the comments in this Q&A session, country ownership is clearly the vital key to successful health and development programs. It's been driven home by the words of every panelist. Where you have a country program like in Egypt, which is owned by the government, not just the national government, but perhaps more importantly, as Mr. Zahran pointed out, the local government, where it engages the religious and community leaders who are trusted by the population, where it reaches across the NGO community, the private sector, and reaches to the population itself with effective communication tools. That's where we see the incredibly strong dividends paying out like we're seeing in Egypt. We're learning from this kind of country program and working to invest in stronger working relationships with every country where we have investments, so that our GHI, our Global Health Initiative strategies, are really capturing the kind of cross-cutting impact that we can make that drive forward all of our health interventions. I think a second key area of learning is on monitoring and evaluation. We heard how important it was that the investment that the government made in strengthening its routine monitoring and evaluation programs, its routine systems, alongside having valuable tools like the DHS and other survey mechanisms, and having a country-trained field epidemiologist system to be able to really identify and use the evidence coming out of these systems to shape and target its programs. In particular, I was struck hearing about the immunization program. You don't achieve 92% coverage unless you have strong evidence systems that allow you to go out and target those areas which are unreached. We're looking to increase our investments in having and enabling countries to make more evidence-based decisions and have greater transparency, both for the countries, but also for us, and how USAID invests in what works, recognizes and highlights what doesn't, and learns from that and takes it forward. And the importance of having that information, not just for the countries, but for us to bring, for example, to our funders in difficult climates like now, is exceptionally important so that we can continue to have the resource flows to important programs such as this one. Lastly, I just want to highlight a little bit on innovation. I think we've heard how the program in Egypt was very much owned by its own population, its own governments, its own stakeholders. No doubt had lots of innovations and entrepreneurs who thought about how they could improve what they did, how they could reach out to the community religious leaders when they were a key linchpin. And I think one of the key issues that USAID is very much fostering right now is looking at how can we help learn from these examples, how can we help share them, south to south has been pointed out, and also how can we help further some of the steps forward with new technologies and reaching out to different problem solvers. So two innovations I would just briefly highlight as an example of the kind of forward thinking that we're trying to bring to all countries is first one called MAMA, which was announced earlier this month by Secretary Clinton in partnership with the private sector, Johnson & Johnson, and many partners. It's harnessing the power of mobile technologies to deliver vital healthcare information to new and expectant mothers. We already heard how critical it was that Egypt had a communication system that allowed it to reach the populations, that allowed it to empower women with knowledge that shaped ultimately their ability to choose and make informed decisions. And this kind of program like MAMA is trying to do the same things, but really building on our new frontier, which is mHealth, having technologies, having phones that really can reach women with information about the best choices for themselves and their children at the point of time they need it. So MAMA will be providing health messaging, text or oral, through mobile phones to inform women when she's pregnant about the ways to care for themselves, to help dispel myths and misconceptions, to help women and their families recognize danger signals when they're in pregnancy, to connect women with health services, and when she has her child, to help reinforce important practices like breastfeeding, explaining the benefits of family planning, and making new mothers aware of how best to care for their infants. So this is being started in 3 countries, Bangladesh, India, and South Africa, and we expect to learn more and have this expanded broadly. But it shows the power of communications and our ability to take that technology forward. The second form of innovation I'd mention is one where we're really looking at the whole issue of saving lives at birth, at that critical moment when a mother and her infant are most vulnerable, when she's giving birth in that period right around then. And flagging that to the entire world as a grand challenge for which we're all accountable. So rather than predetermining the solution and predetermining the problem solvers, what the grand challenge for development is doing, and this particular one on saving lives at birth, that is being done with the USAID, Norway, Gates Foundation, and Grand Challenges Canada, and the World Bank, is to throw out this challenge to the world and invite all innovators from whatever their specialty, engineers, health specialists, educators, the kind of integration that you were highlighting here as being critical. And it opened up that space for them to come forward with the kind of clever, integrated, innovative solutions that we might really take forward in a number of different places. And ensuring that those are scalable. Because what we're looking for are the transformative changes to reaching women, particularly in the poor rural areas. Women who may never have the opportunity to go to a hospital. And so we've launched that first grand challenge. We're delighted at the response. We've gotten several hundred proposals coming in, about half or so from, I think, the developing world, from whole walks of different groups. And we're really looking forward to being able to cull through all of those amazing proposals and see about new ways to take forward, new ideas that can be shared from the countries, with the countries. So with that, I'd like to thank you all for coming today. There's nothing so worthy of celebration as improving the lives of thousands of mothers, children, and families. And this is indeed a triumph for the population of Egypt and the government of Egypt. And it is a model for many other countries to learn from. I'd like to extend my thanks and congratulations also to all of the groups that partnered with the government, with USAID on this, in supporting this effort. Improving lives, saving lives in Egypt and around the world, and having this kind of profound evidence of the impact that it can have is truly inspiring for all of us. So thank you.
Well, thank you very much, Amy, and thank the panelists for a very rich discussion. We thank you also for some excellent questions, and apologies for going over, but it was certainly worth it to have the time that we did. Join me in thanking our panelists once again, please.